I'm going to be speaking on a very interesting topic, posterior reversible encephalopathy syndrome. It's a very important condition to recognize because treatment is very rewarding and patient becomes all right, and it's a real pleasure to see them okay. So today my objective will be to describe what are the symptoms and the risk factors for this posterior reversible encephalopathy syndrome, otherwise known as PRES, to initiate prompt evaluation and treatment and identify the conditions that can emulate PRES, and the evaluation of the diseases so that to improve the patient outcomes, and also learn treatment considerations of what all can be done for PRES and explain how to enhance the case safety outcomes in patients with PRES. So what is this posterior reversible encephalopathy syndrome? This is a clinico-radiological syndrome. It's not mainly clinical. Here radiology plays a very important part. And this is a recently developed concept in neurology. It was not present when I was a postgraduate. It was first described by Hinchey et al. In a small number of cases, patients who were especially receiving chemotherapy. And other names were reversible posterior leukoencephalopathy. That is reversible as it is reversible. Posterior is predominantly the posterior part of the brain is affected. Leuko, white matter, and encephalopathy. Because it affects the posterior white matter, it was known as, and it was reversible, it was known as reversible posterior leukoencephalopathy or reversible posterior cerebral edema. These were the other terms which were used for this condition. So, what is this? This is a condition where there is a patient presents with altered sensorium, drowsiness or sometimes stupor. Visual impairment can be there. Patients can have visual hallucinations, cortical blindness, hemianopia, quadrantonopia, diplopia. And seizures may or may not be there. Seizures can be focal or generalized tonic-clonic and sudden or constant non-local. The patient can have sudden or constant non-localizable headaches. This can occur acutely or subacutely, and usually symptoms develop within hours to days. Presentation usually is associated with uncontrolled hypertension, systolic blood pressure ranging from 160 to 190. Having said all that, sometimes this can occur in a person with a much lesser BP in presence of certain other risk factors or certain drug intake. So, let us see what are the risk factors or triggers. Hypertension is risk factors, triggers or other etiologies will be hypertension. Preeclampsia, you know that this is also a condition where there is hypertension. Kidney disease can be there which can lead to hypovolemia, secondary hypertension, and can produce PRES, liver diseases, cytotoxic medications, immunosuppressants, especially the antineoplastic drugs. And autoimmune disorders like SLE, thrombotic thrombocytopenic purpura, etc. and sepsis can all produce a picture of IIH. Can all produce a picture of PRES. Even yesterday I got a call about a patient who's been on treatment for this coronavirus, who has developed altered sensorium and seizures, and CT scan was showing features of PRES. Sometimes it can occur in very funny conditions. Unless we look for it, we may miss it. This I am going to tell you the story of a 29-year-old Mrs. S. who presented with headache which was severe, holocranial, and it was associated with vomiting for 3 days. 4th day she had one episode of a generalized tonic-clonic seizures. But then headache was excruciating. She was not able to tolerate. She was vomiting and she had seizures and visual blurring were occurring immediately, and she was brought to the hospital. When she came, she was conscious, oriented. It's not febrile, there was no edema, her BP was 160/100, but fundus showed bilateral papilledema. It's not a malignant hypertension, but fundus showed bilateral papilledema. And pupils were normal, EOM, the extraocular movements were full. She had right facial paresis and right hemiparesis with right hemisensory deficit. This is a bit unusual for a PRES. So, first diagnosis would be an infarct if it's possible. So, investigations revealed that most of her counts were normal, the metabolic parameters were normal, liver function was alright, VDRL was non-reactive, and MRI brain was alone abnormal, though MRA and MRV were normal. Let me show you what is abnormality. As you can see, this is anterior, this posterior, and this is a lateral, and this is a ventricle, basal ganglia, and you can see beautifully the internal capsule here. And what has happened? This is a posterior part. Frontal, parietal and occipital. You can see these changes in the white matter in the occipital region. White matter changes in the occipital region, which is suggestive of edema. So, this is the axial section, and in the sagittal section also you can see white matter changes in the occipital region here and here. So, this and some changes in the cerebellar also. So, this is known as posterior reversible encephalopathy syndrome. See, and this is a total MRI. You can see this is a different patient. You can see that it's one side and then sometimes both the sides. It's got different, this is almost all over. It's got different presentation which can affect all parts of the brain. When it's a hollow press, then it can be just occipital, parieto-occipital, it can be there. Then it can be supratentorial, infratentorial, and even spinal press has been known to be present.